hello everybody. So this is the must know series, the last and the final part of this must know series. So this is the first part from the GIT and neurosurgery part. So starting with the first, so what is hydrocephalus? So first we need to understand what is the total CSF volume in the cranial wall. So it is around 150 ml and the rate of production is nearly 20 ml per hour. So if there is an increase in this volume with the ventricle, they enlarge, then it is called as a hydrocephalus, and it is divided into obstructive, communicating, or due to excessive CSF production, which is very rare. So in obstructive, there is usually obstruction to the circulation of the CSF, and in communicating, there is failure of the reabsorption. In excessive CSF production, which is very rare, that is choroid plexus papilloma or carcinoma. In obstructive hydrocephalus, wherein there is obstruction to the circulation of the CSF, it occurs due to lesions which are seen either in the ventricle or the ventricular wall, or the lesions are away from the ventricle but they cause pressure effect and leading to hydrocephalus. And what are the causes of communicating hydrocephalus? So it can be either due to post-hemorrhagic, wherein there is decreased reabsorption, or due to any kind of infection, wherein it will cause increase in the protein and the debris in the CSF, so there will be impaired absorption, or there will be raised CSF protein. So these are the causes of hydrocephalus. Now, what is the role of lumbar puncture in patients having hydrocephalus? So if there is a obstructive hydrocephalus, then we should not do a LP because it will lead to herniation of the brainstem and the cerebellar tonsils, and there will be a resultant herniation known as coning. And in communicating hydrocephalus, it has both diagnostic and a therapeutic value, because diagnostic, it will give us the pressure and also the CSF we can assess what is the likely cause, and therapeutic, we can drain 10 to 30 ml of CSF, which will lead to decrease in the pressure and the symptoms. What is normal pressure hydrocephalus? So it is basically that the CSF pressure or ICP is normal, but there is an ventricular enlargement. It is associated with a triad of gait disturbances, incontinence, and cognition decline. And it is a cause of dementia, which is reversible. It can occur either de novo or post SAH or any kind of head injury or meningitis or due to any kind of tumor. So as I told, ventriculomegaly is evident of imaging, and CSF pressure in this case will be normal whenever we do a LP, and in this treatment is by shunting. That is either temporary or a ventricular peritoneal shunting. What is idiopathic ICF? So there it is basically that there is no pathology, but there is a increase in the intracranial pressure, that is the ICP. It is also termed as pseudo tumor cerebri or benign intracranial hypertension. Now, because of the raised ICP, there is a pressure on the optic nerve sheath, and it can lead rapidly to blindness. It usually presents in young overweight females with headache and visual deterioration. So examination, there will be edema, papilloedema will be there, and there can be also cranial nerve palsies. Imaging, as I told, there will be no features because it is idiopathic without any cause. In lumbar puncture, there will be raised pressure, usually about 25. And diagnosis is usually one of exclusion. So after all the causes have been excluded, if there is still ICF, that is suggestive of idiopathic cause. Management in females, basically we can advise for weight loss, which is sometimes helpful. If OCPs are being taken, cessation of that. For decreasing the CSF production, we give acetazolamide. For visual field or the visual failure or the visual loss, we do either the LP or the VP shunting, or we also do sometimes optic nerve sheath fenestration. These are the two treatment modalities surgically. So this is regarding idiopathic intracranial hypertension. Now coming to treatment of hydrocephalus in general. So if it is an obstructive type, it is basically an emergency because it is also termed as hydrocephalic attack. Now it is relieved by addressing the underlying pathology. But before that, we have to do a temporary drainage, especially in emergency if patient is obtunded or rapidly deteriorating. Or if we want to do a definitive surgery for a tumor, then we have to do precautionary ventricular drainage. That can be done either by EVD, that is external ventricular drainage, or a VP shunt. EVD, so that is temporary measure, CSF drains, and so in this case, a specific pressure threshold is set that is around 10 to 20. So whenever the CSF pressure exceeds that, there is drainage of the fluid, and also we can give intrathecal antibiotics if we want to give through this EVD. Coming to VP shunt, basically it is a tubular structure wherein one end is in the ventricle, like mostly in the lateral ventricle, and the other end is in the peritoneum. That is the ventriculoperitoneal shunt. Other shunts are ventriculoatrial or ventriculopleural. LP shunts are also used in especially in communicating or in idiopathic intracranial hypertension. Now in this, there is a shunt valve, because if there is excess drainage, that is if it is a very low pressure valve, then what will happen is it will overdrain, and if it is a high pressure, then it will not allow adequate CSF drainage. So we need to properly maintain the pressure of that valve so that there is proper drainage of the CSF. Shunt complications, so if there is an over drainage, then there will be low pressure headaches, or it can also lead to a hematoma due to the traction effect, so there will be bleeding or coning. Sometimes in children there is a poor brain compliance, so there is also a syndrome known as slit ventricle syndrome, just know the name. Now shunts are vulnerable to disconnection, infection, and blockage. Blockage usually occurs due to infection, due to the debris and the proteins which get accumulated. So usually the most common complication associated is blockage, but it is usually due to infection. And usually with complication, they usually 75% present with infections in 1 month. Risk factors are if the patient is very young, there is an open myelomeningocele, the OT time has been more, so there is chances of infection, or there is a staph movement which will again lead to increase in the exposure to the microorganisms, so there is increased risk of infection in all these cases. So in these cases, we remove the shunt and we give antibiotic therapy, and as I told, majority of the blockage occurs due to infection. So after the treatment, after the antibiotic has been given, the infection has been cleared, then we can reinsert the shunt. Now coming to a topic from GIT, that is post-operative treatment for colorectal malignancy. So it is usually divided into 4 stages. That is, if it is up to muscularis propria with negative lymph nodes, then it is only we do a follow-up. If it penetrates into the pericolorectal tissues with negative lymph nodes, so it is usually T3N0. In that case, we need to do chemotherapy, especially when, so if it is a poorly differentiated, there is vascular or perineural invasion, there is obstruction in which we have operated, there is a perforated cancer, then we obviously need to give chemotherapy. And if there is any adjacent organ invasion, that is either it is a T3, T4 disease which is poorly differentiated, there is obstruction, perforation, lymphovascular invasion, perineural invasion, and the lymph nodes which are examined are less than 12. So remember that in colorectal tumor, the minimal lymph nodes which are needed is 12. So if less than 12, then we need to give chemotherapy. Now, there is no definite value, but as I said, in high risk cases like what I mentioned, we need to give chemotherapy, especially like oxaliplatin. There is no definitive role of adjuvant, especially if there is no high risk condition, as I mentioned. Now, if the patient has a MSI-H condition, that is expression of an MMR gene, that is usually seen in stage 2 disease, then they have a favorable prognostic significance. Now coming to stage 3, so if the patient is having positive lymph node disease, then we need to give adjuvant chemotherapy. That is, we usually give a Folfox, that is 5-fluorouracil, leucovorin, and oxaliplatin, or we can give Capiox, that is a Zelox regimen, that is oral capecitabine is used. Now in this, various studies have proved that 3 months is inferior, so we usually give in colorectal tumors chemotherapy in adjuvant setting for 6 months. Now if it is a T3 disease, that is only invasion into the pericolorectal tissues with lymph node that is up to 1 to 3, then usually it is a low risk patient. If it is T4 with NEN or N2, then it becomes a high risk patient. So T3 and 1 is low risk, and T4 NEN or N2 disease becomes high risk. So understand this. Now, in low risk patient, usually if we give for 3 months or 6 months, it doesn't make any difference. But in high risk patients, especially if you are giving KPOX, we should give for 3 months, and in FOLFOX, we should give for 6 months. So this has been according to the various studies which has been done regarding the inferiority or the superiority of the 3-month over 6-month regimen. So in high risk, 3 months for KPOX, 6 months for FOLFOX. In metastatic disease, this is very important. Now this has been covered in Savastin. So for metastatic disease, if the patient is having pan-RAS wild type disease or a BRAF wild type, that is BRAF mutation is not there, or RAS mutation is also not there, then in that case we give anti-epithelial growth factor receptor antibodies like panitumumab and cetuximab. For patients having BRAF mutation, we give folfixiri, that is oxaliplatin, with irinotecan, with 5-fluorouracil, with leucovorin. Associated with that, because of the BRAF mutation, we give bevacizumab. But understand, if the patient is having BRAF mutation, then it is associated with a worse prognosis. So for BRAF mutations, we usually give folfoxiri plus bevacizumab. For right-sided tumor that is metastatic, we either give Folfox or Folfiri, or we give Folfixiri with bevacizumab, that is anti-vascular endothelial growth factor antibody. For left-sided, with Folfox or Folfiri, we give either anti-EGFR antibodies, that is cetuximab or panitumumab. So right-sided, we give anti-VEGF. For left-sided, we give anti-EGFR antibodies. And for older or unfit patients, we give capecitabine with bevacizumab. So this is important to remember. For if we are doing a colorectal liver metastatic resection, then we can give either 6 cycles followed by surgery, because we want to avoid hepatic toxicity and we need to maintain the FLR because we are doing a hepatic resection. Sometimes there is a very mixed reasoning for what we do in colorectal liver mets with a colorectal malignancy. So either we do colorectal surgery followed by chemotherapy followed by liver surgery, or we do metastatic disease plus colorectal surgery followed by adjuvant CT, or we give neoadjuvant chemotherapy followed by surgery. So these are various modalities which are used. Nothing is fixed according to a specific guideline. Whenever we are using a bevacizumab, we should stop before 6 weeks of hepatic resection, and we should start 4 weeks after the surgery, because it will affect wound healing, because it is an anti-vascular endothelial growth factor. It will affect the angiogenesis. So we should start 4 weeks after the surgery or once the wounds have healed. So stop 6 weeks before hepatic resection and start 4 weeks after the surgery. So this is regarding bevacizumab. Now, what are the factors which are predictive of non-operative fistula closure? So what are the favorable factors? So if it is a iatrogenic, it is post-appendicitis or diverticulitis, the transferrin level is greater than 200, there is no obstruction, discontinuity, infection or inflammation, then it will be a favorable factor for fistula closure. If it is a long fistula with an end fistula, then sometimes it is at a higher chances of spontaneous closure. If it is a low output, no sepsis, no electrolyte imbalances, and we have given tertiary care from start, then it becomes a favorable factor. If it is a ileal or a jejunal fistula, then it is an unfavorable factor. If it is associated with a IBD or cancer or post-radiation therapy, then all this become very high risk for fistula closure, because it is associated with bowel inflammation. In that case, it will be very less chances that it will close spontaneously. Again, if there is an obstruction, it will not close. If bowel is in discontinuity, again it becomes like an end stoma, so it will not close. There is infection, inflammation. If it is a short segment, then again the tract with epithelize and it will not close on its own. If it is a high output fistula associated with sepsis or electrolyte imbalances, then all these are unfavorable factors for spontaneous fistula closure. Now, GIST management I'm covering because it is important. Questions can be expected. Now, usually we go for a surgical resection. So complete R0 resection is the key, and we need to avoid rupture because it is associated with a very high incidence of recurrence if we rupture the tumor capsule. Laparoscopic approach, usually to avoid the tumor rupture, it is not advisable. When does it become unresectable? Usually they are resectable in majority of the cases, but if it is invaded into the vasculature like celiac trunk, SMA or portal vein, then only becomes unresectable. Otherwise, they are usually resectable, and there is no role of any lymphadenectomy because of no lymphatogenous spread in GIST. So usually we don't do any lymphadenectomy. In small GIST that is less than 2 centimeter, we don't do further treatment. So coming to the management algorithm of this tumor, we need to understand the various mutations and the role of Imatinib. So usually Imatinib is the first line treatment for unresectable, metastatic, and also the resectable GIST. So Imatinib is the first line therapy. Now mutations, usually if there is an exon 9 mutation, then there is a dose dependent decrease in the risk of progression. In this case, we need to give double dose. Usually we give Imatinib 400 milligram, but in this case we need to give 800 milligram dosage. If it is affecting exon 11 or codon 557, 558 of the c-KIT, or it is a D842V PDGFR alpha, this is very important mutation to remember. There is associated higher risk of recurrence. In this case, adjuvant Imatinib therapy is not recommended, especially in D842 PDGFR alpha mutations, because there is resistance to this drug. So usually in this cases, whenever it is Imatinib or Sunitinib refractory, then we use Dasatinib, especially in D842 PDGFR alpha mutations. For advanced GIST, that is after Imatinib or Sunitinib fails, then we give Regorafenib. For Imatinib and Sunitinib resistant tumors, we can also use Sorafenib. And wild type GIST, that is no specific mutations, in that case is usually we give combined Imatinib and doxorubicin. So coming to the treatment algorithm, if we are able to resect the GIST, then we should go forward with surgery. If not, then we should assess for the mutations. If in that case there is sensitive mutation, then we should give Imatinib for nearly 1 year. If not, and we need to see if R0 or R1 resection is feasible. If after giving Imatinib and resection is possible, then we should go forward with surgery. If not, then also we should go according to the advanced or metastatic GIST algorithm. Now, if patient post-surgery, we should assess the tumor for the c-KIT mutations. If it is associated with a high risk of recurrence, then we should give 3 years of Imatinib. And if low risk, then we should just do disease surveillance. So this is for the localized GIST. Now coming to the advance of the metastatic disease, we assess again for the c-KIT mutation. If yes, and exon 11, we give Imatinib 400 milligram. If exon 9, then as I mentioned earlier, we give double dose, that is 800 milligram. Now in both the cases, if there is a response to Imatinib, then we continue for nearly 1 year, and then we check if there is a response in the tumor in form of shrinkage, and we can do surgery. Then we should do surgery followed by continuation with Imatinib therapy till there is a progressive disease. Now if in all of this, that is Imatinib, there is a response, we give one for 1 year, but after that there is no response or there is a limited progression of the disease, then we can either do a tumor debulking followed by adjuvant Imatinib for like till it is progressive. If there is no response and there is no limited progression, then in that case, if it is resistant to Imatinib, so I told we shift over to Sunitinib. So in either Imatinib in exon 11 or exon 9, whenever there is no response to Imatinib or there is a progression with Imatinib, we shift over to Sunitinib. Now in that also, if it is not a stable disease or there is no response, then we shift over to Regorafenib. In that case, if there is slower progression, then we can continue Regorafenib. That means it is somewhat effective. If there it is not at all responsive, so there is a like progressive disease, then in that case we can re-challenge the patient with Imatinib, or we can shift over to chemotherapeutic regimen. So this is all about the treatment of GIST. In exon 9, double dose, D842, we go for Dasatinib. Regorafenib, whenever it is failure of Imatinib or Sunitinib. Sunitinib whenever there it is failure of Imatinib. Sorafenib in Imatinib and Sunitinib resistant. And when do we give Imatinib? Usually we give in adjuvant setting, and also whenever it is an unresectable or a metastatic GIST. First and always it is Imatinib which is used. Now coming to brain tumors, so basically it presents with seizures, raised ICP, and focal deficits. So it is a triad of patient presenting with seizures, raised intracranial pressure, and deficits due to either compression or due to surrounding edema because of the tumor, or compression over certain eloquent areas leading to seizures. So most common intracranial tumor is cerebral metastasis, and most commonly it arises from lung. That is important to understand. If multiple cerebral metastasis, that means a very advanced disease in that it is not suitable for surgery. Diagnostic biopsy should be done whenever we don't know regarding the primary, if it is unknown. In cases with a good functional status of the patient with a well-controlled systemic disease, so if the systemic disease or the primary is well controlled and the patient is good status, then we can go for craniotomy and resection of a single, and maximum we do resection up to 3 metastasis. So this is from Bailey basically. Coming to glioma, so tumors arising from the glial cell are known as glioma. Diagnosis is always histological. Investigation, usually MRI is preferred over CT. CT is only done for metastasis. MRI is the preferred imaging modality in these patients. To the differential diagnosis between brain abscess, we go for a diffusion weighted MRI. So that is important to understand in glioma. To reduce the tumor associated edema, we give steroids. Because of the edema also sometimes there is a higher chance of seizure, so steroids helps us to decrease and control that symptom. We give anti-epileptics, and if it is resectable, then we go for surgical resection. Now classification, it is divided into 4 grades, that is grade 1 to grade 4. Grade 1 is also known as pilocytic astrocytoma, and all the gliomas can have a diffuse infiltration into the surrounding brain except for the grade 1. So understand, grade 1 are the most benign form which does not infiltrate into the surrounding structure. Now coming to grade 2, which is also low grade glioma, it usually occurs in 4th decade, but they can encroach on the eloquent part of the cortex which is usually functioning. So in that case, we may need to do a awake craniotomy whenever we are planning for a surgical resection. And coming to grade 3 and grade 4, so grade 3 are also called as anaplastic astrocytomas, and grade 4 is known as glioblastoma. So grade 1 is pilocytic, grade 3 is anaplastic, and grade 4 is glioblastoma. Now grade 4 and grade 3, usually they are the commonest glial tumors, again seen in the 5th to 6th decade. In this case, we need to do maximum tumor debulking followed by radiotherapy, chemotherapy, and chemotherapy usually is done as a local application of carmustine wafers, and systemically we give temozolomide, and usually median survival is nearly 1 year. These are all the important points which you need to remember to answer if any questions is asked from this part, so don't miss this. Lastly, coming to meningioma, so these are basically benign lesion which arises from the meninges, and they usually present with symptoms of mass effect, that is obstructive hydrocephalus. On imaging, they will appear as a contrast enhancing mass which is distinct from the brain. So they will occur between the cranial vault and the brain. So they will appear as a contrast enhancing mass or a hyperechoic structure. They are, as I told, benign, so they are slow growing, and they are incidentally detected in elderly patients, in which case we can just do a wait and watch approach. In large, we give steroid to reduce the edema and plan for surgery. Important point to understand is regarding the recurrence. So usually if we have done a proper R0 resection, we can achieve a recurrence rate of only 10%. If we have done a subtotal, there is recurrence rate increases up to 30%. And lesions which are not resectable, we give radiotherapy or stereotactic radiosurgery. So this is the first part. I have covered the most important portions from neuro and especially the colorectal and the small intestinal tumors in this. So I hope it is clear. Just go through this. It will help you to answer any question if asked from this topics. Thank you so much for watching.